Hello and good morning to this session on social and community welfare provision. I'm Dr. Anita Khoso, your facilitator for this unit. So a bit about what this unit is about. I'll give you a bit about um, an understanding of what you should be expecting in this project. So yeah, a bit about myself as well. So I'm Dr. Anita Khoso, and I'm a lecturer at the University of Greater Manchester, Bolton. And I teach medicine and public health. So this is what we will be doing in a nutshell. So this is social and community welfare provision, and it is a graded unit. So there are three learning outcomes that you will be covering with me. So this is to understand the factors that influence health. So now we will explain to you the key social issues in contemporary society that have an impact on health. So different aspects that may have an impact on health, whether to improve health, whether to reduce health, etc. And we will discuss how these issues affect health and well-being. Then we will go on to understand the development of the social and community welfare provision, where we will define key milestones in the advancement of social and community welfare provision. We will also compare and contrast current health service provision with preceding healthcare services. And then the third learning outcome is to understand the values adhered to in service provision. Here we will discuss the core values that underpin social and healthcare service delivery, and we will also go on to identify the ethical issues that underpin social healthcare delivery. Okay, I hope this session is being recorded. Okay, so these are recorded sessions. So the grading of this session of this unit overall will be based on your knowledge and skills, subjects which include subject-specific skills and your transferable skills. Okay, so that's about it. So the indicative content is the learning outcome 1, which we will cover now. We will talk about the social issues and how they impact health and well-being, such as requirements, your needs, lead, accessibility, demand sourcing, funding, postcode lottery, etc. Learning outcome 2 will be an understanding of the development of social and community welfare provision, where we will talk about milestones in the advancement of social and community welfare provision, developments and changes in health and social care during the Industrial Revolution. Yeah. And then the 19th century public health services. So these will be part of our discussion. And then learning outcome 3 will be to understand the values adhered to in service provision, where we will talk about the core values that underpin social and healthcare service delivery behaviors, taking responsibilities for actions, achievement of excellence, monitoring, development bias, and unbiased approach and professionalism. So these are some of the core things that we will be discussing. I'll just share my slides with you. Just give me a minute. And I'm audible as well. Sorry. So we are understanding the factors that influence health. Okay, this is what our objective for today is. So this is a video basically that shows some of the key terminologies that I will be talking about. This video. You can see it when you have your on your Moodle website. It talks about community-centered approaches for health and well-being within the NHS. Okay, so what is social and community welfare? So a program, social welfare system. It offers assistance to individuals and families who are in need with such programs as healthcare assistance, their food stamps, for instance. There's unemployment compensation. So if you're unemployed, you're getting support for that. Also, lesser known parts of a social welfare system, which include disaster relief and educational assistance. Within England, the social care is defined as the provision where you have social work, you have personal care, you have protection or social support services to children or adults in need or at risk, or adults with needs arising from illness, arising from disability, from old age, or poverty. What does social welfare mean in the UK? So, social welfare law is the term used in the UK, which describes those areas of civil law in which there are people on low incomes and they are typically disadvantaged. And these are the ones who are prone to experience difficult times. Internationally, the poverty law is used. Okay, that is the term that is used internationally at international level. What are the main objectives of social welfare? So, in other words, social welfare aims at providing services to those who are very underprivileged. There is a separate section within the population, and this is to provide them with various sources of various forms of social insurance against poverty, unemployment, disability, and old age. Some examples of social welfare within Britain. So you have Britain is a welfare country, welfare-led country. So the welfare benefits in the UK, these include 5 separate groups of services. You have cash benefits, you have healthcare, you have education, you have housing, and personal social services. The most widely used form in the UK are cash benefits, and these make up around 10% of the gross domestic product. So this is a major chunk. The category of cash benefits, they can be broken down into 3 subgroups. So these are national insurance, they're means tested, and non-contributory benefits. The national insurance system makes up the lion's share, the largest of the social expenditure in the UK, while the non-contributory benefits rank second and means tested benefits are the last ones to come. So you have the national insurance system, you have then non-contributory benefits, and then means tested benefits. Within UK, we have a problem where there has been low benefit levels. For instance, pension benefits are less than half of a person's active salary, unfortunately. Healthcare is the second major part of the UK's welfare system. The first is cash, monetary benefits. It is then healthcare benefits. This is organized through the NHS, and financed by our taxes. The system is popular and it's relatively cost effective by the standards of other countries. As it is universal, it covers the entire population and it is virtually free to people. Priority is given to those who are in dire need of medical assistance, yet those who need non-emergency medical services, they must wait sometimes up to 2 years. Then education is available to all school ages in children through the ages of 5 to 16 years. But then children who reach 16 years, fewer lower class children move on to further their education, and instead they directly move into workforce because obviously they need the money and they don't have means to get themselves educated because it's costly. In short, the system of higher education, it does reflect a class bias again. The responsibility of the British education system, it lies within the central government, the local government, and other professional interests. All three have a part in these three. This is the central government, the local government, and professional interests. They have a part in public school system. The central government provides for a legislative framework for the schools, and you have the local government, which generally focus on the organization of the schools. Professional interests, they tend to influence the curriculum and testing procedures. Public housing, it mainly consists of council-owned rented houses. Okay, that is the main chunk. The owner or occupation housing, however, is the most popular in the UK, mostly because it is based on a taxation subsidy system. There are three-fourths of working class actually, who are homeowners in the UK who live in sub-dwellings. Okay, social housing is council housing, sorry, is controlled by the local government and usually provided by applying a means test. As in most other Western countries, when you have aging of population, it is one of the biggest challenges of the welfare state in the UK. The government in the UK is faced with a growing elderly population. So we see a change in the demographics. So then there's not much in uh, rise in the population because there's birth control measures. Okay, people are reproducing less. However, they're growing to an older age, more of them, and this requires for them more assistance and services. But the demographic problems are not as pronounced as in some other European countries. As another very important issue affecting social policy, and it is the level of unemployment. It skyrocketed in the 1980s to 13%, but has come down to about 6% in the mid 1990s. The problem of unemployment is also coincided with high rates of inflation. The Conservative Party responded to these challenges by promoting job training, and this was done especially to younger people, sorry. The reason was that high unemployment occurred mostly among untrained manual employees. There's some key milestones that need to be mentioned in community health services policies. So this is community-centered approaches for health and well-being. So it's strengthening communities where you have community development, you have asset-based methods, and you have social network approaches. Then you have volunteer and peer roles. This is bridging roles. So we were talking about the issues and the timeline, basically. So in 1948, we had the community health services that are responsible for the public health arm of the local authorities. 1962, so 1962, you have the hospital plan that emphasizes the need to expand services in the community. 1963, the health and welfare highlights a wide variation in local authority community service provision. Then you had the Gilly report that emphasized the importance of GPs being supported by a wider primary care team, the need for closer integration between GPs and other services, and in 1965, the report of the CBOM community that calls for better coordination between social care and other health and welfare services in the community. 1974, the responsibility of community health services that were transferred to the NHS. This was to tackle poor coordination between community and hospital services. Area health authorities were created, and joint planning and consultative committees were formed within the local authorities. So we were just focusing on this as well, where there's volunteer and peer roles, there's bridging roles, there's peer interventions, peer support, peer education and mentoring, and volunteer health roles. Then collaboration and partnerships. So there was community-based participatory research, area-based initiatives, community engagement in planning and co-production projects, and then access to community resources where there was pathways to participation, community hubs, and community-based commissioning. Going further on in the timeline, 1987, there was promotion of better health proposals, the development of primary care teams with GPs working alongside health visitors, community nurses, and other professionals. In 1988 to 89, the Griffiths report and Caring for People highlighted the fragmentation of community services and emphasized the need for collaboration between the NHS and local government. They set out proposals for local authorities to plan and manage the social care, but not necessarily to be direct providers. This leads to significant growth in the independent sector provision. 1989, this was following the publication of Working for Patients, Community Services, and there was increasingly establishing themselves as standalone NHS community trusts. In 1997, the new NHS was there. There's modern, dependable, describes the aim to deliver more integrated health and social care services in the community. Primary care trusts were established, and most community health services were effectively merged into PCTs. PCTs are these primary care trusts. Then in 2000, there was the NHS plan, a plan that was there for investment, a plan for reform proposal, redesigned primary and community services, creating 500 new one-stop primary care centers and investment in intermediate care. The option to form care trusts is introduced, but it is relatively few that are set up. 2006, Our Health, Our Care, Our Say sets out a wide-reaching strategy to shift care out of hospitals and expand community provision, including by shifting resources. There's a variety of measures that were introduced to promote integration, to improve access, and strengthen prevention. 2000 2008 has high quality care for all. NHS next stage review recommends the separation of these primary care teams or trusts, and the commissioners and provider functions, and PCTs are directed to consider a range of organizational models for community services. Then there was next stage review. So our vision for primary and community care, which encourages greater pooling of resources by these PCTs and the local authorities, and the development of new tariffs to encourage more provision of healthcare in the community. Continuing from there, so to 2009, there was transformation of community services, which enables new patterns of provision, which requires primary care trusts to come up with a strategy for community services and to identify future organizational models, separating their commissioning and provider functions. 2012, you had the Health and Social Care Act, which transfers responsibility for commissioning community health services from primary care trust to newly informed CCGs. Just a minute. But not missing out anything. So just give me a minute. So, yeah, sorry for that. Health and social and future organizations and operational models, separating their commissioning and provider functions. That 2012, you had the Health and Social Care Act. There's transferred responsibility for commissioning community health services from primary care trust to newly formed CCGs. Some services included public health and health visiting, and they're transferred to local authorities. In 2014, the NHS 5-year forward You had the NHS 5-year forward view, which sets out a vision of how NHS services need to change in order to meet future needs of the population. And there was argument for greater emphasis on prevention, integration, and putting patients and communities in control of their health. It calls for a shift in investment from acute care to primary and community services, and it outlines several new care models as well. Then 2015, you further have so the NHS 5-year plan was put forward. Then you had in 2015, where NHS organizations were directed to come together with local partners to develop sustainable and develop a transformation plans, STPs. There were 5-year plans for health and care services in their area. 2016, the 44 STPs are published, and all includes proposals to redesign primary care and community services, and it is often expected that this will reduce demand for hospital care. December 1986, there was Sir Roy Griffith's report, which was commissioned by the Secretary of State to undertake an overview of community care policy. So this is also known as the NHS Management Inquiry, which was a report commissioned by the UK government in 1983. And this was to investigate the management and efficiency of the NHS. The report was authored by Sir Roy Griffith, who was a management consultant and former director of J. Sainsbury Company. The report made a number of recommendations, and this was to improve the management of the NHS, which included the introduction of a more business-like approach to healthcare management, the development of clear lines of accountability, and need for greater efficiency and cost control. The report was controversial at the time, with some critiques arguing that it placed too much emphasis on the principles of the private sector, not enough to the needs of the patients. Nevertheless, this report had recommendations and that have long-lasting impact on the NHS. Many of its recommendations are being implemented over the years. The report is often cited as an important document in the history of the NHS, and its legacy can be seen in the current management structures and approaches to healthcare management in the UK. You have the Marmot Review, very famous comprehensive report on health inequalities in England. It was published in 2010. The report was co-authored by Sir Michael Marmot. He was a public health expert and professor at the University College London. It's commissioned by the UK government. This report is there to examine inequalities on health outcomes. Okay, there's shorter life expectancy, worse health outcomes for those who are in lower socioeconomic status compared to their counterparts. The report also found that health inequalities were increasing in England despite overall improvements in health outcomes. There were a number of recommendations also that were made based on these reports, and there were recommendations made of him on employment, on health, on public health initiatives, social welfare programs. This report has, this Marmot Review, it has a significant impact on public health policy in England. Many of its recommendations are being implemented over the years. The report helped to raise awareness of the social determinants of health and the need for a more holistic approach to healthcare, and this addresses the root causes of health inequalities. The report also influenced the development of Health and Social Care Act 2012, and this aimed to improve health outcomes and to reduce the health inequalities in England. The NHS. So the NHS provides comprehensive health care throughout the United Kingdom. The hospital, it's a tripartite structure. Just give me a minute. Or a 3-tiered structure. Okay. Just give me a minute. Sorry. So what happens within this tripartite or this 3-tiered structure is that within it you have primary care, you have hospitals and community care. So that's primary care, hospitals and community care. the main element is in the primary care is the system of GPs or general practitioners who are known as family doctors, and they provide preventive and curative care. What happens within them is that it's all consultations within the NHS, they're free, and so it is led by a general practitioner. Major types of primary medical care, they include dentistry, and you have pharmaceutical and ophthalmic services. These are the only services of the NHS which where charges are levied through persons under age 16, past retirement, and with low incomes, and they're usually exempt. Everyone else must pay charges that are below the full cost of the services involved. Then under the Department of Health in England, there are 4 regional health directors, and they oversee the health authorities. It's Scotland, Wales, Northern Ireland, and they're responsible of their respective parliament or assembly. Hospitals absorb more than 2/3 of the NHS budget, a lot of it. All hospital treatment on the NHS is free. This includes consultations with the doctors, nursing, drugs, and intensive care. Whatever the type of medical problem and however long the hospital stay. Hospital doctors, they are paid a salary rather than a fee for service, but can combine salaried work for the NHS with a private practice. So the community health service has 3 functions. It is to provide preventive health services, to act as liaison with local government, especially over matters of public health, and to cooperate with local government personal social service departments to enable health and personal care to be handled together wherever possible, whenever possible. So there's a video that shows contemporary issues in healthcare. We had talked about this also. What are the main problems? We talked about the aging population. We said that the population is shrinking, but there's an aging population which is increasing in number. This means that there's healthcare needs, increased cases of obesity, diabetes that come with old age. Antibiotic resistance, medical advancement save lots of lives every year, but push up costs also at a considerable pace. Top line facts on the big issues in health and social care: the nation health, NHS performance and waiting times, health and social care funding, and health and social care workforce. Why communities matter? Now coming towards this problem, towards this issue, that communities are very important and they matter a lot. So why communities matter for health? Placing communities at the heart of public health can reduce health inequalities because you're working at ground levels. They can empower people to have a greater say in their lives and in their health, and create connected, resilient, more cohesive communities. So as this figure said, community life connections, social connections, and having a voice in local decisions are all factors that make a vital contribution to health and well-being. So when these community ties broke up during COVID-19 or were interrupted, this was the reason for major unhealthy a decrease in well-being within the communities. So community-centered ways of working, are important for areas of public health, health improvement, health protection, and healthcare public health. So involving and empowering local communities, and particularly those who are disadvantaged groups, is central to local and national strategies in England for both promoting health and reducing health inequalities. The NICE guidelines, they are there, which focus on the importance of community engagement as a strategy for health improvement, particularly as it leads to services that better meet the community member needs. Being connected matters for your health. So loneliness and social isolation, they damage your health, especially young people and older adults when they lose their interactions. Community Life Survey 2016 to 17 found that 5% of adults in England reported that they felt lonely, often or always, and this has remained unchanged since 2013. But not all people have someone to rely on, and over 54% or over half of this people stated that they felt lonely hardly ever or never. Health inequalities persist, and many people experience the effects of social exclusion or lack of social support. The Marmot Review is that evidence. And building social capital with community-centered approaches. So it is very important. So you have community-centered approaches to enhance community and individual and community capabilities to create healthier places and to reduce health inequalities. Community-centered approaches are not just community-based, but also mobilize assets within the communities, promoting equity and enhancing people's control over their lives, over their health. Most local authorities embrace community-centered ways of working, but the challenge that many are now seeking to achieve is the scaling up of a whole system, community-centered and asset-based approach that is built bottom-up from the diversity of grassroots community organizations and members. The family of community-centered approaches it has developed as a framework to represent some of the practical and evidence-based options that can be used to improve community health and well-being. This includes 4 strands of community-centered approaches for health and well-being. These are strengthening communities, volunteer and peer roles, collaborations and partnerships, and access to community resources. Now, last but not the least, we are going to discuss some very important points. Which will take very less time for us. So now we go on to explain the key social issues and contemporary issues that have an impact on health. There are health inequalities, social factors such as poverty, there's housing, compared to those who are more affluent, those who are poorer, they have more poorer health outcomes. Mental health is one thing that has been impacting, and it's a stigma for a very long time. It can prevent people from seeking help when they need it. The aging population, so UK has an aging population. This is placing increased pressure on the healthcare system. Older population are more likely to have complex health needs and require more intensive care than younger people. Obesity, major public health problem, non-communicable disease. Obesity is linked to several other range of other health conditions, including heart disease, diabetes, and cancer. Social isolation, it's a growing population, public health problem. People experience loneliness and social isolation. They're connected. Social isolation is linked to poor mental health, can have negative impacts on physical health as well. These social issues have a significant impact on the UK healthcare system, and they increase the demand for services and a need for new approaches to healthcare delivery. Addressing these social issues can be crucial for improving health outcomes and ensuring the sustainability of the healthcare system in the future. Now, lastly, we discuss how these issues affect health and well-being. So health inequalities, we've talked about this. People are living more healthier lives if they have more, and they're living in a better socioeconomic status. They have lesser communicable and non-communicable diseases. Mental health problems are increasing, common in the UK. They have significant impact on people's health and well-being. Mental health problems can lead to feelings of isolation, depression, anxiety, and other issues that have a negative impact on the physical health as well. Aging population, so in the UK, it has led to an increased demand for healthcare services, particularly in areas such as long-term care and rehabilitation. This has put strain on the already fragmented healthcare system. Obesity, linked to a lot of other problems, social isolation, we've talked about this. When we address these issues, it is very important that we have it as a multifaceted approach, not just one target. Okay, so and we need to keep Marmot's review also in consideration when we are doing this. So these were the references that were used to bring about this presentation together. There's further reading that you can access as well. If there are any questions, the recordings will be shared with you. If any other questions, please email us at learnerwork@ukversity.co.uk or use the WhatsApp channel. Thank you so much for listening to us. Thank you. Take care and bye.